5 members of the primary healthcare team are assembled for their weekly 8 a.m. meeting. The purpose of this meeting is to develop a plan of action for the clients. Present in the meeting are Nancy Furlong, the social worker, Simon Wilson, the pharmacist, Kathy Kane, the family physician, Terry White, the registered nurse, and Sheila McKinsey, the occupational therapist.
It's 8. Let's get started. Does everybody have a list of the patients we're going to review today? All right, our first patient is Henry Keogh. Now, Terry, you're the nurse assigned to this case, and you did want to present your patient. Why don't you go ahead and start?
Sure, yep, 1 second now. Yes, Mr. Keogh. Okay, he's a 35-year-old male with type 1 diabetes, onset at about age 8. He lives alone in a 2-story townhouse, so he injects Novoline 30/70 insulin twice daily. He's got good control of his blood sugar. His diet's a bit iffy because he has a sweet tooth and he likes junk food, even though I've repeatedly told him about it. His eyesight's been declining over the past year, and I expect it will continue to decline, but it's well enough that he can drop his insulin and he can do things like get the key in the door, that type of thing. So he's basically safe enough at this time. He's due to come in for some blood work soon, some routine blood work, and I've got a podiatrist scheduled to see him and to check his feet and to cut his nails. So I'm sure he'll be fine.
If he's stable, why are we discussing him? We have such limited time, and I have a lot of work to do. We need some rules for these meetings if we're going to get anything out of them.
Dr. Kane, I've listened to your presentation, no matter what you choose to focus on. The information I'm presenting here is very important, and it's exactly what we agreed these team meetings would be about. I'm telling you, he's stable now, but he's likely to be at risk of accident or hypoglycemia in the near future. I think this presentation is highly relevant.
We're supposed to present cases that seem complicated and require the input of others. Those are our ground rules. Terry, was there something specific that you wanted us to review in this case? Do you think I need to discuss with him about his declining vision and any other supports he may need?
Sure, I'll tell him about you when he's in today.
I could see him as well and assess his need for visual aids.
How about the medications that Mr. Keogh is on? Is there something that Simon should review?
Medications. Any medications besides insulin?
He's on Ramipril 10 milligrams 1 daily, enteric-coated aspirin 81 milligrams 1 daily, simvastatin 40 milligrams 1 daily, and diazepam 10 milligrams for sleep, and he sometimes repeats that once.
Diazepam. Diazepam's a really bad drug for long-term treatment of insomnia. He shouldn't be on diazepam.
Really? He's been on diazepam for 5 years.
Can you recommend a different drug or a different dose? Sleep problems are common. What should we know?
Sorry, I thought nurses would have known about sleep medications. Long-term treatment of insomnia with benzodiazepines is not recommended. Patients get tolerant to the sedative effects and then get addicted to the drug, and no one wants to stop it. It has a very long half-life. It's at least 2 days, which causes problems that all hypnotic drugs have, such as hallucinations, agitation, changes in memory, and gait. Actually, it turns out that Benadryl in low doses, say 25 milligrams, can be effective and relatively free from harmful side effects. Sometimes the anticholinergic effects of Benadryl can be a problem, but that can be monitored.
Thanks, Simon. We'll all think more carefully about sleep medications from now on.
What's the history of the sleep problem? Maybe he doesn't even need it anymore and could be tapered off over time. Do you think it's a serious problem like sleep apnea that wakes him?
No, it doesn't sound like sleep apnea to me.
It seems like you'll work on the sleep problem. I'm concerned about his nutrition. Do you think I need to get a diet consult?
I've tried to get him to change his diet, but he's just not compliant. Maybe a consult will help. Sure, why don't you set it up?
I've got a full day already. Well, if you don't think you can handle it, I guess I can. Anything else?
I'll arrange a home visit to assess his needs further.
Let's move on to the next patient.